Retropupillary IOL implantation for subluxated intraocular lenses, crystalline and artificial without capsular support. Jan Boos from Netherlands designed his first version of the lobster claw IOL in the late 70s. Two different sizes are today available. It is designed primarily as an anterior chamber IOL fixated on the outer, non-moving part of the iris. Nevertheless, sometimes one claw loses its fixation, and this will compromise the corneal endothelium in nearly every case. This problem can be solved, on the other hand, if this IOL will be fixated on the rear side of the iris. The Miyake view in vitro will demonstrate the claw fixation here when the same IOL is implanted retropupillary. In this clinical case, with an atrophic iris and pseudoexfoliation, the in-the-bag PMM IOL is subluxated. This patient complains about severe dysphotopsia and reduced vision. The capsular bag, together with the IOL, will be moved now into the anterior chamber, which is already filled completely with a viscoelastic substance. The periphery of the capsular bag shows a large shimmering ring. After maneuvering the capsular bag IOL complex in front of the iris, it is explanted with a strong forceps through a 5 mm limbal incision. After core vitrectomy, which is not shown here, Myohol plus visco is again injected into the anterior chamber. The sphincter of the iris does not react, and therefore careful mechanical constriction of the iris should perhaps help. This manipulation does not look really elegant, but it helps definitely to bring the periphery of the iris more centrally. Here at 12 o'clock we can also see the peripheral iridectomy, which becomes very important for our new IOL implantation technique. A normal varisize, a phakic IOL, is taken out of the container. With this special forceps, which has quite strong mini claws. The curve of the IOL is intended to keep a gap between the iris tissue and the PMMA. The IOL is therefore implanted with a curve downwards into the anterior chamber. With a second instrument, the claws of the IOL are rotated now to the 3 and 9 o'clock position. With a little hook here, normal chopper, the iridectomy is now brought into the visual axis, and now the special forceps IOL is introduced through the main incision and through the iridectomy, and in the pupil area the very size IOL is grabbed in the mid-center and torn underneath the iris. Look and look. The pupil is now as round and as small as possible in this case. Lifting the right claw against the iris, enclavation with the help of a spatula against the shining through claw is not too difficult. And the same procedure is performed on the opposite side. Finally, removing of the visco and pressurizing the AC will bring the IOL exchange to a nice end. Second case with a normal iris sphincter will demonstrate again the major steps of this retropupillary IOL implantation. First, the IOL forceps with its very strong mini claws. Then the forceps is guided through the main incision and the iridectomy. And in the pupil area, the claw will grab the IOL in the outer center. And now the IOL is carefully guided behind the iris. Pupil shrinks immediately together. Lifting the IOL against the rear side of the iris, the edges of the IOL claws can be seen and detected for the enclavation. Very small folds. In the iris tissue in the periphery will indicate the iris fixation. And here. Thank you for your attention.